10 questions. Control of breathing. Pause after each question if you need time to think. Let's go. Question 1. Which respiratory center is primarily responsible for generating the basic rhythm of quiet breathing? A. Pneumotaxic center. B. Apneustic center. C. Dorsal respiratory group. D. Ventral respiratory group. Pause if you need to think. The answer is C. Dorsal respiratory group. Here's why. The respiratory control system has multiple components, each playing a distinct role, and knowing which does what is essential for boards. The dorsal respiratory group, DRG, is located in the dorsal medulla, specifically in the nucleus tractus solitarius. This is the pacemaker of quiet breathing. It generates the basic inspiratory rhythm automatically, producing rhythmic bursts of neural activity that drive the inspiratory muscles, primarily the diaphragm, via the phrenic nerve. During quiet breathing, inspiration is active, driven by the DRG, and expiration is passive. The DRG simply stops firing. Elastic recoil does the rest. The DRG receives input from peripheral chemoreceptors and lung stretch receptors, modifying its output based on the chemical and mechanical state of the patient. The ventral respiratory group, VRG, located in the ventral medulla, is primarily active during forced breathing, exercise, hyperpnea, when active expiratory muscles need to be recruited. During quiet breathing, the VRG is largely silent. The DRG does all the work. Dorsal respiratory group, pacemaker, quiet breathing, inspiratory rhythm, phrenic nerve output, diaphragm contraction. Question 2. The primary function of the pneumotaxic center is to A. Stimulate expiration, B. Inhibit inspiration, C. Detect arterial oxygen tension, D. Sense CSF pH. The answer is B. Inhibit inspiration. Here's why. The pneumotaxic center, located in the pons, specifically in the parabrachial nucleus, acts as a brake on inspiration. Its primary function, to send inhibitory signals to the dorsal respiratory group, turning off the inspiratory drive, limiting the duration of each inspiration. By limiting how long each inspiration lasts, the pneumotaxic center regulates both tidal volume and respiratory rate. Strong pneumotaxic center activity, shorter inspirations, smaller tidal volumes, faster respiratory rate. Weak pneumotaxic center activity, longer inspirations, larger tidal volumes, slower respiratory rate. This is why the pneumotaxic center is sometimes called the respiratory off switch. It works in opposition to the apneustic center, also in the pons, which promotes sustained inspiration if not inhibited. The pneumotaxic center normally overrides the apneustic center, preventing excessively prolonged inspiratory efforts. If the pneumotaxic center is damaged or removed experimentally, the apneustic center dominates, producing apneustic breathing, prolonged gasping inspirations with brief, ineffective expirations. Pneumotaxic center, pons, inhibits inspiration, limits tidal volume, regulates respiratory rate. Question 3. Central chemoreceptors primarily respond to changes in A. Arterial PO2, B. CSF pH, C. Plasma bicarbonate concentration, D. Arterial oxygen content. The answer is B. CSF pH. Here's why. The central chemoreceptors are located on the ventral surface of the medulla, bathed in cerebrospinal fluid. They do not directly sense arterial CO2. They do not directly sense arterial PO2. They do not sense plasma bicarbonate. They sense hydrogen ion concentration, pH, in the cerebrospinal fluid immediately surrounding them. Here is the mechanism. CO2 rises in the blood, as in hypoventilation, exercise, or increased metabolism. CO2 crosses the blood-brain barrier freely and rapidly. Inside the CSF, CO2 reacts with water via carbonic anhydrase to form carbonic acid, which dissociates to H+ and bicarbonate. The H+ lowers CSF pH. The central chemoreceptors detect this fall in CSF pH and powerfully stimulate the medullary respiratory centers, increasing respiratory rate and tidal volume, increasing CO2 elimination, restoring CSF pH toward normal. This is the dominant drive for breathing in normal conditions. Central chemoreceptors are responsible for approximately 70 to 80% of the total ventilatory response to CO2 in a normal person. The clinical implication: opioids, benzodiazepines, volatile anesthetics, propofol all depress the central chemoreceptor response to CO2. This is the primary mechanism of anesthetic-induced respiratory depression. The CO2 rises, but the central chemoreceptors can no longer detect and respond to it appropriately. CSF pH, not PO2, not plasma bicarbonate, the primary signal to central chemoreceptors. Question 4. Which substance readily crosses the blood-brain barrier to influence central chemoreceptors? A. Hydrogen ions. B. Bicarbonate. C. Carbon dioxide. D. Lactate. The answer is C. Carbon dioxide. Here's why. The blood-brain barrier is formed by tight junctions between cerebral capillary endothelial cells, creating a selective barrier that strictly controls what enters the brain and cerebrospinal fluid. Carbon dioxide, being a small, lipid-soluble, uncharged molecule, crosses the blood-brain barrier freely and rapidly. This is why rising arterial CO2 so quickly and powerfully stimulates central chemoreceptors. The CO2 enters the CSF within seconds, reacts with water to form H+, and the chemoreceptors respond. Hydrogen ions, charged particles, cross the blood-brain barrier extremely poorly. This is a critical distinction. Metabolic acidosis, increased H+ in the blood, does not rapidly stimulate central chemoreceptors, because H+ cannot easily cross into the CSF. The peripheral chemoreceptors, carotid and aortic bodies, are exposed to arterial blood directly, and they do respond to arterial H+ and pH. So in metabolic acidosis, the respiratory compensation, hyperventilation, is driven primarily by peripheral chemoreceptors responding to the low arterial pH, not by central chemoreceptors. Bicarbonate also crosses poorly and slowly. Lactate does not freely cross the blood-brain barrier under normal conditions. Carbon dioxide, freely, rapidly, always. The molecule that directly connects arterial ventilation to central chemoreceptor activity. Question 5. The Herring-Brewer inflation reflex is mediated by activation of A. Irritant receptors, B. Peripheral chemoreceptors, C. Lung stretch receptors, D. J receptors. The answer is C. Lung stretch receptors. Here's why. The Herring-Brewer inflation reflex is a protective lung reflex that prevents overinflation. As the lungs inflate during inspiration, slowly adapting stretch receptors in the airway smooth muscle are activated. These stretch receptors sense lung volume. When lung volume reaches a sufficient threshold, the stretch receptors send afferent signals via the vagus nerve to the medullary respiratory centers. These signals inhibit further inspiration and promote expiration. In effect, the lung tells the brain, "I am full enough, stop inspiring." This reflex prevents tidal volume from becoming excessively large during each breath, protecting against pulmonary overinflation and barotrauma. In humans, the Herring-Brewer reflex is most active at high tidal volumes, greater than approximately 800 to 1,000 milliliters. During normal, quiet breathing, it plays a modest role. In infants, this reflex is much more prominent and important. It actively contributes to respiratory rhythm regulation in the neonate. In the context of anesthesia, Positive pressure ventilation activates stretch receptors with each delivered breath, influencing respiratory drive and contributing to apnea in spontaneously breathing patients who receive large tidal volumes. Vagus nerve. Lung stretch receptors. Inflation inhibits further inspiration. Question 6. Which receptor is most likely responsible for rapid, shallow breathing in a patient with acute pulmonary edema? A. Lung stretch receptors. B. J receptors. C. Central chemoreceptors. D. Muscle spindle receptors. The answer is B. J receptors. Here's why. J receptors, juxtacapillary receptors, are located in the alveolar walls, in close proximity to the pulmonary capillaries. They are specifically sensitive to pulmonary capillary engorgement, increased interstitial fluid, inflammatory mediators in the alveolar wall. In acute pulmonary edema, pulmonary capillary pressure rises, fluid leaks into the interstitium, and eventually into the alveoli. This engorgement and edema directly stimulates J receptors. Their activation produces rapid, shallow breathing, hypopnea at high frequency, reflex bronchoconstriction, and a sensation of breathlessness or air hunger. The rapid, shallow breathing pattern of acute pulmonary edema is a classic J receptor effect. Clinically, this is the breathing you see in a patient with acute decompensated heart failure, rapid, labored, shallow breaths, orthopnea, the sensation of needing to sit upright to breathe. J receptors are also activated by pulmonary emboli, pneumonia, exposure to certain chemicals, and by the volatile anesthetic agents, which is one mechanism contributing to respiratory irritation during inhalational induction. J receptors, juxtacapillary, alveolar wall, pulmonary edema, rapid, shallow breathing. Question 7. Central chemoreceptors increase ventilation primarily because elevated CO2. A. Directly stimulates neurons in the medulla. B. Decreases arterial PO2. C. Produces H+ within the cerebrospinal fluid. D. Increases plasma bicarbonate concentration. The answer is C. Produces H+ within the cerebrospinal fluid. Here's why. This question reinforces the core mechanism established in question 3, but approached from a different angle. Central chemoreceptors do not sense CO2 directly. They sense the consequence of CO2 entering the CSF. CO2 crosses the blood-brain barrier, enters the CSF, reacts with water via carbonic anhydrase, forms carbonic acid, dissociates to H+ and bicarbonate. That H+, that increase in CSF hydrogen ion, that fall in CSF pH, is what the central chemoreceptors actually detect. More H+ in CSF, greater chemoreceptor stimulation, greater drive to increase ventilation. The ventilatory response is therefore a response to CSF pH, not directly to CO2 itself. This distinction has important clinical consequences. In chronic hypercapnia, as in chronic COPD, the kidneys compensate by retaining bicarbonate, normalizing arterial pH. But cerebrospinal fluid also eventually equilibrates. Its pH returns toward normal despite the elevated CO2. The central chemoreceptors become less sensitive to the chronically elevated CO2 because CSF pH is no longer as abnormal. This is why chronic COPD patients may rely more on peripheral chemoreceptor drive, hypoxic drive, for their ventilatory stimulus, and why giving supplemental oxygen to a CO2 retainer can theoretically further blunt their already compromised ventilatory drive. CSF H+, not CO2 directly, the signal to central chemoreceptors. Question 8. Which nerve carries afferent information from the carotid bodies to the medulla? A. Facial nerve. C. N7. B. Vagus nerve. C. N10. C. Glossopharyngeal nerve. C. N9. D. Hypoglossal nerve. C. N12. The answer is C, glossopharyngeal nerve, C. N9. Here's why. The peripheral chemoreceptors, carotid bodies and aortic bodies, are the sensors in the circulation that respond to arterial chemistry. They respond primarily to low arterial PO2, particularly when PaO2 falls below approximately 60 millimeters of mercury. They also respond to increased PCO2 and decreased pH, though less powerfully than central chemoreceptors respond to CO2. The carotid bodies, located at the bifurcation of the common carotid artery, are the dominant peripheral chemoreceptors in humans. They send their afferent signals via the carotid sinus nerve, a branch of the glossopharyngeal nerve, CN9, to the nucleus tractus solitarius in the medulla. The aortic bodies, located near the aortic arch, are smaller and less important in adult humans. They send their afferent signals via the vagus nerve, CN10. This CN9 versus CN10 distinction is a classic board question. Carotid body, CN9, glossopharyngeal. Aortic body, CN10, vagus. Remember it simply. Carotid, CN9. Aortic, CN10. Different chemoreceptors, different nerves, same destination, the medulla. Question 9. Which nerve carries afferent information from the aortic bodies? A. Glossopharyngeal nerve. B. Phrenic nerve. C. Vagus nerve. D. Sympathetic chain. The answer is C. Vagus nerve. Here's why. As established in question 8, the peripheral chemoreceptors have distinct nervous pathways to the medullary respiratory centers. The aortic bodies, located near the aortic arch and pulmonary artery, send their chemosensory signals via the vagus nerve, CN10, to the dorsal respiratory group in the medulla. In humans, the aortic bodies are less physiologically significant than the carotid bodies for ventilatory control. The carotid bodies are the primary peripheral chemoreceptors in humans. The aortic bodies may play a greater role in cardiovascular reflexes, blood pressure and heart rate regulation than in ventilatory control. But both peripheral chemoreceptor groups respond to the same stimuli: low PaO2, high PaCO2, low pH. And both contribute to the overall peripheral chemoreceptor drive to ventilation. The clinical importance. Peripheral chemoreceptors are the primary ventilatory drive when central chemoreceptor sensitivity is blunted, as in chronic hypercapnia, or when opioids and anesthetics suppress central control. This is why hypoxic drive becomes relatively more important in certain disease states, and why abolishing hypoxic drive with supplemental oxygen in some COPD patients can reduce ventilatory drive. Aortic bodies, vagus nerve, CN10. Different from carotid bodies and CN9. Board distinction. Memorize both. Question 10. Which respiratory center sends its output to the diaphragm via the phrenic nerve? A. Pneumotaxic center. B. Dorsal respiratory group. C. Apneustic center. D. Ventral respiratory group. The answer is B. Dorsal respiratory group. Here's why. This question brings everything full circle back to question 1. The dorsal respiratory group, the pacemaker of quiet breathing, not only generates the basic inspiratory rhythm, it also executes it. The DRG sends descending motor output via the spinal cord, ultimately reaching the phrenic nerve, the nerve that innervates the diaphragm. Phrenic nerve origin, cervical nerve roots, C3, C4, C5. The classic mnemonic, C3, 4, 5, keeps the diaphragm alive. DRG fires, phrenic nerve activates, diaphragm contracts, thorax expands, inspiration occurs. DRG stops firing, phrenic nerve quiets, diaphragm relaxes, elastic recoil drives expiration. This direct connection between the medullary DRG and the phrenic nerve is why high cervical spinal cord injuries, above C3, cause complete diaphragm paralysis and respiratory failure. The DRG output cannot reach the phrenic nerve if the cervical cord is injured above that level. This is also why phrenic nerve injury, from surgical damage during cardiac surgery or thoracic procedures, causes unilateral diaphragm paralysis. The communication between DRG and that hemidiaphragm is severed. Dorsal respiratory group, inspiratory pacemaker, phrenic nerve output, diaphragm contraction, the fundamental motor act of breathing. That is 10 questions. Control of breathing. Your 5 things to lock in before you go. Dorsal respiratory group, medulla, pacemaker of quiet breathing, sends output via phrenic nerve to diaphragm. C3, 4, 5 keeps the diaphragm alive. Pneumotaxic center, pons, inhibits inspiration, limits tidal volume, regulates rate. Central chemoreceptors, ventral medulla, sense CSF pH. CO2 crosses blood-brain barrier freely, generates H+ in CSF, dominant ventilatory drive in normal conditions. Carotid bodies, glossopharyngeal nerve, CN9. Aortic bodies, vagus nerve, CN10. Peripheral chemoreceptors respond to low PO2, high PCO2, and low pH. J receptors, juxtacapillary, alveolar wall, activated by pulmonary edema and capillary engorgement, produce rapid, shallow breathing. I'm Anesthesia Buddy. Stay sharp. See you in the next one.